Well, welcome to today's program. I'm Dean Kereiakes, the president of the Christ Hospital Heart and Vascular Institute and professor of clinical medicine at The Ohio State University. Today's program is coronary intravascular lithotripsy: who, what, where, when, and why, an introductory guide for clinical practice. And we have an all-star cast, starting with Bobby Ye, who is the director of the Richard and Susan Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center, associate professor of medicine at Harvard. We have Ziad Ali from the Cardiovascular Research Foundation at St. Francis Hospital. Philippe Genereux, director of structural heart and the interventional cardiology program at the Gagnon Cardiovascular Institute in Morristown, New Jersey. Rich Shlofmitz, chairman of cardiology at St. Francis Hospital, and Robert Riley, who's a research and program director of the Complex Coronary Therapeutics program at the Christ Hospital Lindner Research Center. And at this time, I'd like to turn it over to Bobby Ye, who will give us the first presentation.
Thanks so much, Dean. I'll be giving the first talk in this session. It's titled, Who? Interventionalists' Unmet Needs in Calcium Modification. These are my disclosures. Coronary calcification is quite common. In fact, it is common across all ethnic groups. It is common in both men and women, and it rises with age. You can see here that approximately 70% or 80% even of men by the time they reach the age of 70 have evidence of coronary calcification, and it's about 60% for women at that same age, so highly prevalent in an aging population. Now, when we think about coronary calcium in the setting of PCI, we have to think first about what are our procedural goals in general in PCI, and in particular among complex calcified lesions. And what we're trying to do, of course, is to perform PCI safely. That's the avoidance of major complications. We're trying to do it efficiently. We need to be able to deliver the stent efficiently without having to do anything particularly dangerous or onerous. And finally, we want an optimal mechanical result, and that equals good, excellent stent expansion in the place that we want to deliver that stent. So coronary calcification, as everybody in this audience knows, increases the difficulty with all of those things. And really, it's an unmet clinical need to be able to do this safely, to deliver stents safely with and efficiently. And we know that patients who have coronary calcification have a greater risk of procedural complications, including dissections and perforations. We know clinically that it's much harder to deliver a stent in tortuous calcified anatomy. And finally, we often are able to finally deliver these very deliverable stents, but unfortunately not able to expand them. And underexpanded stents can lead to the risk of stent thrombosis or target lesion revascularization. So let's go over these one by one. The impact on coronary calcification first at impeding stent delivery. We know that coronary calcium is an independent predictor of not being able to deliver the stent. And that's because stents, although highly conformable compared to previous stents, still lack the flexibility to advance through calcified arterial segments. And secondly, the stents themselves can be damaged. We've had stent edges that get hung up on spicules of calcium, and that can be problematic. It can actually even lead to stents dislodging from the balloon. So typically, before we put in stents in, we might do predilation, including high pressure predilation with a non-compliant balloon. But even with non-compliant balloons, we know that high pressure balloon inflations have limited impact on eccentric calcium. What happens is they can push the calcium away from the lumen, and these balloons are typically unable to modify deep or very thick calcium at all. So the typical tool that we've turned to is coronary atherectomy in these situations. Coronary atherectomy is really an excellent technology or set of technologies that we use. I certainly depend on them routinely for complex PCI, but we have to admit that they have some limitations. They require a dedicated wire, a wire that's not necessarily the easiest to manipulate down the vessel. There's thermal injury, which can produce platelet activation. Distal embolization associated with no reflow is a problem. Finally, you're unable to protect significant side branches with atherectomy, and there's a chance, ever so rarely, with potentially large perforations due to transection of the wire. And because of the limitations and people's operators' concerns about coronary atherectomy, there are many individuals, there may be some in this audience, who aren't all comfortable, or not altogether comfortable doing coronary atherectomy. And as a result, may from time to time end up implanting a stent either with suboptimal atherectomy or without it at all, and get an underexpanded stent. And this underexpanded stent can be associated with worse complications for the long term. We know that the greater the arc and length and thickness of calcium, the more likely it is that a stent is underexpanded. And these suboptimal results that we appreciate are probably even more frequent than we observe. And that's because we don't always, as much as maybe we should for these complex lesions, we don't always do intravascular imaging. But when intravascular imaging is done, we know that asymmetrical stent expansion is frequently seen in patients who have calcific disease, and up to 50% of stents. And the real problem here is what it means for patients. So here we can see some outcomes associated with coronary calcification. This is 7 contemporary stent trials, pooled analysis of stent trials comparing patients with calcified lesions versus those without. And we can see for important endpoints like all-cause mortality, combined death and MI, and combined death, MI, and any revascularization, coronary calcium is associated with worse outcomes. These curves separate immediately because they are procedural issues, and they continue to widen over time as the effects of underexpansion are involved. These results are seen in other sets of studies besides that one I just showed you. Here, a pooled analysis of the Horizons AMI and Acuity trials again showed that coronary calcification was associated with much worse one-year outcomes across a variety of endpoints. So in conclusion, calcified coronary lesions are frequent problems in today's cath lab due to the aging of the population, and they are frequent in both men and women and across ethnic groups. Their presence increases the risk of periprocedural MACE during PCI. And we can mitigate this risk with calcium solutions like atherectomy and cutting balloons. And these devices do help. They help for stent expansion, and they help us facilitate successful procedures safely. But IVL is a novel calcium treatment solution that can tackle currently unaddressed challenges, particularly deep, thick calcium, bifurcation lesions, calcified osteal lesions, calcified lesions in large vessels, and calcified tortuous lesions. So a new technology that's really going to add to our armamentarium of tackling this difficult challenge. Thanks very much. Now I'll hand over to our next speaker, Dr. Ziad Ali from St. Francis Hospital. Ziad?
Well, thanks, Bobby. It's my pleasure to be able to present to you on the principles of coronary IVL. My name is Ziad Ali from St. Francis Hospital and Heart Center and the Cardiovascular Research Foundation in New York.
So now
this is a very early description of intravascular lithotripsy. And what you see on the right panel is actually that the MacGyvered lithotripsy has blown the eggshell off of the egg itself, but the membrane is completely intact. And this is as good as evidence as any that the fundamentals of IVL are soft on soft and hard on hard. And 9 years later, this is where we are. Intravascular lithotripsy is incorporated into a balloon with expanding and collapsing vapor bubbles, creating a short burst of acoustic pressure waves. These acoustic pressure waves travel through the vessel with an effective pressure of approximately 50 atmospheres. And this localized field effect within the vessel fractures both superficial and deep calcium, really facilitating vascular compliance, stent expansion, and maximum luminal gain. So to understand this, there are various different ways by which you can create a shockwave, but we're going to focus on extracorporeal shockwave lithotripsy, which is the technique used to essentially manage kidney stones. So on the left side, what you see is a spark plug. A spark plug creates a spark between two electrodes that creates a shockwave. The shockwave actually resonates inside an ellipsoid reflector. The best way to think of that is kind of like the mirrors around the inside of a flashlight next to the bulb, because what they do is they take this unfocused energy and focus it, thereby applying a very high focused energy to the kidney stone itself. And in the middle, what you'll see is these bipolar electrodes create a first shock wave, which creates a compressive effect, and then an expanding cavitation bubble, which actually lead to a host of different mechanism of actions, which I'll show you on the next slide. But it's important to understand the waveform of an extracorporeal shockwave lithotripsy, and that is that there's a very short, extremely rapid rise in pressure. This is followed by a fairly significant magnitude negative pressure, an aftershock, and then a stabilization. And so the mechanisms of fracture are multiple. The compressive stress is actually the initial shock wave hitting the calcium and creating the initial fractures. A shear stress occurs within the calcium itself as the shock wave propagates in the calcium. At one point, the shock wave hits the back wall of the calcium, the interface between the soft and hard, and actually leads to a pulling effect, creating an inverted pressure. And finally, there's a tensile strength, which leads to these microjets and heat within the calcium, fracturing it in all different directions. And finally, a squeezing stress, which is dependent upon the differences in impedance of the inside and the outside of a stone. These same features are germane to intravascular lithotripsy, in particular compressive stress. And what you see in the lower inlet here is in red, the external shockwave lithotripsy pressure waveform, but in the inset, the intravascular lithotripsy waveform. And the most noticeable thing is that the magnitude of the IVL is much, much lower compared to ESWL. And while that seems simple as just turning down a dial, in fact, it is not that simple and requires a lot of careful engineering focused towards safety. And if we look over here on this right-sided table, you'll see that the energies that are generated by external shockwave lithotripsy are far beyond anything that we would want in the human body, certainly within a blood vessel that's 2.5 or 4 millimeters. 300 to 1100 atmospheres of pressure, minus 80 to minus 150 atmospheres of negative pressure. This would really pulverize and perforate the artery. But if we look at intravascular lithotripsy, we're moving from focused energy to unfocused, so we dissipate some of this energy on purpose. Our peak pressures are around 50 atmospheres, very utilitarian in contemporary interventional cardiology. The negative pressures are low, and that's important so that we don't pull the calcium away from the back wall and create a perforation. And the penetration depth, again, is consistent with what's required in interventional cardiology, approximately 3 to 7 millimeters. And as I mentioned, these multiple mechanisms, IVL's predominant mechanism is really compression stress. It's important to also understand the field effect. There are various different catheters available, the C2 for the coronary, the S4 and the M5 for the periphery. And these catheters are purposefully designed in an important way, and that is to focus energy in a way that's germane to the procedure that's required. So the coronary catheter has two emitters. The first emitter is 4 millimeters from the radiopaque marker from the balloon. The second emitter is 6 millimeters away from the first emitter, and then there's a 2 millimeter gap towards the second opaque marker of the balloon. And that's important because you can't always see the radiopaque marker. And so what you need to do is understand that these electrodes create the most energy immediately perpendicular to the electrode themselves. And you'll notice in the M5 channel that there's a much larger field effect. And the reason is because this is the single emitter that has its own channel. So there's more energy delivered in this middle channel. It's also important to understand the field effect to utilize your pulses to the maximum effect. Now, when you have an undersized balloon, much of the energy is lost actually in the space between the balloon and the wall. Optimally, what you want is the balloon to be in contact with the artery wall, in contact with the calcium, so that the shock wave has minimal interference between leaving the electrode and getting into the vascular wall and the calcium. And in fact, it's also important again to realize that there are spaces between the electrodes and that the maximum amount of energy is immediately perpendicular to the electrode. And therefore, moving these emitters up and down the coronary to be immediately adjacent to the calcium is actually very important. And what you see is that in the Disrupt PAD study, those patients who had the optimal technique performed had a much better long-term primary patency. And so if we look at the mechanism of action in a cartoon form, we have this unfocused lithotripsy energy. The electrical energy is delivered to the emitter, initiating the steam bubble, which expands and collapses, creating a sonic pressure wave. And that pressure wave then hits the calcium and generates the first compressive stress and fracture. And so summarized, IVL is a sudden, short, unfocused burst of energy that can lead to calcium fracture. On the contrary, the ultra high pressure balloon is a slow, sustained increase in pressure, somewhat analogous to a weightlifter, where lifting it up from the bar or your chest is much harder than lifting it up when you have a spotter. And this mechanism of action translates directly into calcium fracture, evidenced by micro CT as well as OCT. And you'll notice that these fractures are not always linear as we see on OCT. Rather, the unfocused energy creates somewhat chaotic calcium fracture, which can be helpful because we're not pulverizing the calcium, we're leading to many fractures. What we're used to seeing is these calcium fractures in a OCT cross-section, which appear to be linear. Nonetheless, these are highly valuable because the sites of these fractures facilitate an improvement in vascular compliance with balloons and stents. And when we look at the mechanism of action, you see that compared to pre-procedure, there's a significant increase in the minimal lumen area post-IVL because of this liberation. But then following this, the stent actually pushes these two tectonic plates away from each other and provides us a further increase in the post-stent minimal stent area. So when we compare the different mechanism of actions of rotational, orbital, and intravascular lithotripsy, you notice some important differences. IVL allows any wire to be used. Lesion crossing is probably a little bit more difficult than a non-compliant balloon. Wire bias is eliminated because the balloon inflates and provides circumferential calcium modification. Side branch protection can be done with a wire. It doesn't need to be removed because of it, and there's no atherectomy effect. There are theoretically no increased distal embolization risks. The perforation risk is theoretically the same as a high pressure balloon. Shock topics do occur, but with minimal hemodynamic effect. There is no plaque ablation, but there is effect on deep calcium, irrespective of whether or not there's soft tissue in between the lumen and the calcium itself. So in summary, IVL utilizes electrical energy to generate acoustic pressure waves, which impacts calcium. Acoustic pressure impacts calcium by multiple mechanisms. And compared to the others, IVL energy lower, keeping with its goal to fracture but not pulverize calcium. Adequate balloon size is critical to effective IVL, substantiating the utility of IVL in severe calcium. And understanding the spatial placement and separation of the IVL electrodes can help with case and pulse management. The mechanism of fracture is an acoustic pulse, which is short and sharp, and both in vitro and in vivo studies confirm fracture as the mechanism. IVL is clearly an important tool in modification of coronary calcium. Thanks very much for taking the time to listen to me talk about what's under the hood with IVL, and on to Philippe, who's going to be talking to you guys about specific areas where IVL may have additional clinical impact.
Thank you, Ziad, for such a great overview of shockwave therapy. So it's a real pleasure for me to discuss where I believe IVL shockwave has some value and describe some specific anatomical locations where I used it and I believe it has a real role. I'm Philippe Genereux. I'm from Morristown Medical Center, where I'm the director of the structural heart program in interventional cardiology. Here is my disclosure. So I'm presenting obviously on behalf of our center, where we have approximately done more than 50 cases in various clinical presentations, STEMI, non-STEMI shock, left main, osteal lesions, and bifurcation. And I believe that the two last, osteal lesions and bifurcation, may have a very specific role for shockwave. The good thing about intravascular lithotripsy is we can use it in a real world patient and in many type of scenario. These are just few graphic example where shockwave have been used in large vessel and left main anatomy, bifurcations, tortuous vessel with osteal disease. These are cases where actually we use balloon usually, where you can use also shockwave. IVL has been integrated into clinical practice, and I'm going to share an algorithm that we may use or use as a guidance when and where to use IVL. But first of all, you need to recognize that calcium is present. And the first thing is, if you see calcium on angiogram, and then if you see something, says something, if you see calcium, you should use actually IVL or consider using IVL. And especially if there's a dog bone on non-compliant balloon. So if you use a non-compliant balloon, 1:1 ratio with a proximal with a distal vessel, and you still have dog bone, this is a good case where you should consider IVL. Obviously, when you have calcium, you can start with a non-compliant balloon, and we know that IVL could be used after aggressive balloon dilation, especially when there's dissection. You should consider IVL when there's dog bone on a non-compliant balloon, when there's thick and deep calcium, and especially in osteal and bifurcation lesion. When the lesion is very, very narrow, very tight, and it's difficult to cross with any balloon, this is where atherectomy can play a role. When there's a big nodule of calcium, this is where maybe you need more debulking. When there's superficial, very thin and superficial calcium, this is maybe a good place for atherectomy. And when it's diffuse calcium, maybe you want to atherectomize first. Scoring balloon and cutting balloon also may have a role, but less used, especially actually if you want to use as a first line therapy and you use NC balloon and you want to use scoring cutting balloon. And if there's very, very focal and thin calcium. And this is an algorithm that has been developed by my good friend Margaret McIntaggart in Scotland and James Pratt in UK. And this is where you can consider this multiple therapy and integrate IVL in your algorithm. So first of all, you need to assess the presence of calcium on the angiogram. And if you have calcium, or if the balloon cannot cross, this is where you decide to use different considerations. So first you assess the calcium, okay? And if you have very thin calcium and very superficial calcium, you can use a non-compliant balloon or atherectomy. But if you have a nodular calcium or a big nodule, this is where you should use maybe a rotational atherectomy also, or laser. When there's calcium that is more than 180 by imaging, either IVUS or OCT, and is very thick, this is where IVL might be a good choice. One other consideration, this is where when there is a bifurcation with a large side branch with an angulation, this is where IVL may have a role. So I strongly believe that you should image as much as possible to detect calcium and to determine how extensive is the calcium, less than 180 or more than 180, and how deep it is. If it's a deep calcium and more than 180, I think Shockwave is a good tool. The more calcium there is, the more efficient it will be. If it's really less than 180 or a big nodule, maybe you should go with another technology. And I think Shockwave has a big value, like I said, when the vessel is more than 2 millimeter, obviously, when it's left main or osteal RCA, and when there's a big bifurcation or a bend in the body wire. So let's talk about a few cases. So this is a case where I use IVL and bifurcation. It's a very recent case, less than 3 weeks. So 69 years old male, came with usual risk factor, is a survivor of a lung cancer with the right lower lobectomy in 2014. And he described typical angina, CCS 2 out of 4, and it with exacerbation 3 out of 4. This is the angiogram that show an intermediate lesion in the RCA, and intermediate lesion also of the OM1. We're going to discuss what we did with these two intermediate lesions. And this is where the problem was, and you can see very severely calcified proximal mid LAD with a diagonal involving the calcium. And you can see you don't even need OCT or IVUS. You see calcium on both sides of the wall, more than 15 millimeter, extremely calcified lesion involving a bifurcation. So that was the problem. So the patient was turned down for surgery because of the extensive porcelain aorta. And one findings we see with patients with calcium in the coronaries is that they are very high risk and they have calcium everywhere. And this is a good example. So the plan was to perform a physiologic assessment of the RCA and the OM1 and to perform a PCI of the LADD1 with guidance of physiology. And I'm going to show you what we did and use IVL Shockwave on the LAD. So we did a FFR. Actually, we used the absence opto wire that used DPR, which is similar to IFR, which was non-ischemic on the right. And also absence DPR that was negative on the OM1, which is really turned the cases in a single vessel disease LADD1. So we start the case with a DPR. So we use the absence wire, the FFR wire, the same wire we use for the RCA and the OM. We just put in the LAD and we wired the diagonal with the workhorse wire. And on the FFR wire, on the absence wire, we use two balloon where we pre-dilate. And this is the NC balloon 3L, and you see this is a dog bone. There's no doubt about that. So this is where I decided to use the Shockwave balloon. So you can see here how the Shockwave crossed easily the lesion that was very difficult to cross with the non-compliant balloon. And obviously we had a body wire in the diagonal, but this Shockwave balloon very crossed easily in this lesion. This is the Shockwave. We did multiple inflation pulsation with the 3O Shockwave. And this is post-Shockwave. You see a very good result already with the balloon. And the bifurcation is still intact. And this is what I like with the IVL is you keep the flow of work of bifurcation. You don't change any wire. You don't lose side branch. It's very reassuring, actually. And then we start to put some stents where you put the mid-LAD stent, the prox stent, and we post-dilated with a 3.5 at 26 atmosphere. We did a little kissing balloon after that with a 3.5 non-compliant and a 2.5 in the side branch. And this is the final result, okay, with a very good result in the LAD and the flow which is preserved in the diagonal. It's a small vessel. I didn't want to put the two stents. So in summary, we did everything on the FFR wire, on the absence wire, with physiology guidance, with a very good result after with the DPR, which is almost normalized in the LAD, and we'll pull back the absence wire and put in the diagonal, also almost normal in the diagonal. So purely physiologically based cases with a Shockwave and severely calcified lesion. The last case I want to present is the IVL in osteal lesion. And this is a case I did recently on a 73-year-old male post-CABG, came with a non-STEMI inferior wall. And you can see here the tight lesion of the ostium of the RCA and a very calcified, like all calcified are the CABG, a post-CABG patient. So very simple. I use actually a Shockwave balloon again. This could be very challenging for orbital or rotational atherectomy because you can cut the wire, you can injure the aorta. So this is where I love to use simple technique, and I believe IVL is very useful in the osteal lesion. So I use an FFR wire just to prove actually again that it was positive, is significant. So the absence wire DPR is 0.7. And then on this same wire, on the physiology wire, I brought the IVL Shockwave at 3.5. I did multiple inflation and pulsation with a very good expansion. Then after I put a big DES, drug-eluting stent at 3.5 at 15 millimeters, so cover the ostium with a little bit of flare in the aorta, always on the physiology wire. I post-dilate aggressively with a 4.0, and you can see very beautiful inflation, very good expansion. And this is the final view. As you can see, very good flow, very good expansion of the stent with physiology after the case of 0.98. So clearly a good result. Obviously, we could have used imaging, but I believe and we can talk in the discussion, but I believe with a physiology of 0.98 with a good visual expansion, I think this is enough. So in summary, why IVL in these lesions or in certain anatomy? First of all, what I like the most about IVL is you preserves standard flow of work, and everybody can use it. It's easy, and this is really the only technology that can work on a standard workhorse wire 014. So you don't change your flow of work. You can even use a FFR wire or an absence wire where you do the assessment first and then you treat with IVL and you do the FFR physiologic assessment after. So that's a big plus for me to use a standard wire. Then you preserves wire access of the side branch in terms of bifurcation, which is, I believe, in when it's very tight bifurcation, a 1-1-1 very tight side branch, it could be very reassuring. Then the safety profile of this device is very reassuring, especially in iris locations such as less main, ostial lesion. When it's the last remaining vessel, it's just a balloon like all the other balloons, so it's reassuring. And the good thing is if you dissect or you use a thyrectomy, for example, before, you can still use IVL to further expand the lesions. So overall, really simplify the treatment of calcified lesion, and that's one of the reasons I like this therapy. So thank you for your attention. It was a real pleasure to present my cases, and now I will turn my attention to Richard Shlofmitz, who's going to talk about OCT and imaging during these cases of IVL.
Thank you, Philippe, for the introduction. I'm pleased today to talk about intravascular lithotripsy for the treatment of severely calcified coronary artery disease, focusing on the DISRUPT-CAD3 OCT substudy. These are my disclosures. And what I'm talking about today is the DISRUPT-CAD3 study. And I'm honored to be part of the substudy of OCT, which there were 100 patients. And there was an OCT subset and a non-OCT subset. And what I liked about the OCT substudy is, to me, it was one of the most important imaging interventional trials there was. And I'll tell you why. Is because before you could enroll in this study, you had to document with imaging, with OCT, greater than a 270-degree angle of calcium. So without pre-treatment, effectively, you had to show that you were dealing with the most calcified lesions. In addition, before you were able to use a balloon or stent, you had to image again to document that you had fracture in the calcium, and finally image a third time to show what the stent looked like, what your MSA was. So this is really the first study that I know of that you imaged, not making a diagnosis of calcium based on angiography, but based on imaging greater than 270, and documenting the effectiveness of the therapy before you used other balloon therapy as strategy to get your stent result. So these were de novo heavily calcified lesions, 2.5 to 4.0, with greater than 50% stenosis and less than 40 millimeters in length. And if you look at the procedural characteristics between the OCT and non-OCT arm, and what I love is that the OCT arm actually took less time than the non-OCT arm, and that's because we were able to use precision pulse management where we know exactly where we're working. So whether you used OCT or not, the time was not different, and there really weren't any major difference in stents or catheters used. With the measurements with the OCT, pre-intravascular lithotripsy, the minimal lumen area was an average of 2.2, post-therapy 3.6, and post-stent 6.5. So you see rather nice gains along each step, whether you from lithotripsy to your stented area. And the maximum calcium angle was 293 degrees, and malapose drugs were rare, and the minimal stent area was 6.5 when we were done. And here you look at the luminal gains, and we see that we had a positive MLA shift, not only after stenting, but also after IVL with a balloon inflation at 4 atmospheres. So we had real nice luminal gain. Complication rates were extremely low, very similar to CSI. Immediately post-IVL, very low complication rate, no reflow phenomenon not seen, slow flow rare, closure not existing, perforation not existing, dissection rare, as well as serious angiographic. And the final results were really stellar. When we go to the in-hospital and 30-day MACE for the total study, once again, the results are quite good, comparable to other atherectomy trials with high calcified lesions. So the MACE rate was very low. But again, what I love to show is that the performance and safety outcomes with OCT, if you look at the end of procedure with OCT, the dissections, perforations, abrupt closure, slow flow, and no reflow, 0 at the end of the procedure. And the 30-day MACE with OCT, virtually 0 as well. So the results with this study show that this is a very safe and effective procedure, but it's even safer and more effective using imaging to guide you. Now, this is an example of how we proceed with calcified lesions. We have a prescriptive algorithm for the treatment of calcium, and it's based on imaging with OCT. If you can OCT and get the catheter across, you can then identify if calcium is deep, superficial, or nodular. And if you can't cross, well, then you need to go to orbital atherectomy or rotablator. But once again, you're going to want to document calcium fraction before you stent. In the OCT arm that you can cross, you can see if it's superficial and circumferential calcium greater than 180 degrees, and you could cross with a balloon. Something like IVL is a great technique. So this algorithm is really simple and nice to help you get the best results. I'm going to present now a case study of a gentleman who had significant LAD disease that was calcified. He had atherectomy to the LAD. And now we bring him back for OCT and IVL of the right coronary artery. And what I like about the OCT, it lets me give pulse management to try to get the best result I can. Here's the baseline angiogram, and you can see I have a calcified lesion. And I really would ask anybody, can you tell me what type of calcium is in that vessel by the angiogram? And I don't really think it's possible. You know it's calcified, and you need to take it seriously. So the beauty of OCT following the algorithm is we could identify the calcium. Is it present? The answer is yes. You can see that clearly on the cross-sectional image on the top right. And very important is I can measure the length of the calcium and the depth of the calcium and the arc of the calcium. So I could see, will conventional balloon technology give me fracture to have good stent expansion? Because if you don't get good stent expansion, you have an increased risk of restenosis. So here I see that I have greater than 5 millimeters of length of calcium. I see that my depth is going to be greater than 0.5. I can actually measure the size of the vessel. And this is going to be important with IVL because I need to get 1-to-1 stent balloon to size of the vessel to get the maximum energy. But here I'm measuring the length. It's 0.76. 0.66, and the arc is going to be greater than 180 degrees. So if you go back to our algorithm, you'll recall that this CVI score is 4, and we would want to go with some type of ablative technique, and this would be ideal for intravascular lithotripsy. This again is just showing us the arc of calcium. You can see that the non-calcified area is 26 degrees, with the majority being calcified, and you certainly can't tell that from the angiogram. So we go ahead with lithotripsy, and we want to know how long a balloon, what size balloon, and what size stent. So we pick a distal marker, we pick a proximal marker with the best looking vessel, and where we see heavy calcium, you can see in the middle screen, there's superficial calcium with some nodular component. We go ahead and deliver our IVL catheter. If your OCT catheter crosses, your IVL catheter will cross. And we had balloon expansion. You see the waist at 8 pulses. And we treat. And now afterwards, we're going to document before we stent that we had evidence of fracture. If I have evidence of fracture, I'm going to go ahead then and either balloon or stent after that to get my final result. But sometimes after we do Shockwave, and here you see the fracture over there at 10 o'clock. And you see fracture here at 9 o'clock. So we have nice fractures along the vessel area, which is what we're looking for. So we're going to have predictable stent expansion. But sometimes what we measure initially is not the same as afterwards. So we always measure length and size after we do IVL before we stent. So we're going to go ahead and do that and measure, and we can tell you exactly the length of stent we want to get the best normal to normal tissue landing zones and the best size of the reference. So we have really good luminal gain, and we'll get stent apposition and maximize our results. So here we see we're going to take a 23 millimeter stent. We have the size, 3.5, and go ahead, and now we're going to stent the vessel. So post-IVL, you see the fracture. That's the angiogram. And now we take a final outcome after we stent. And we always checked afterwards. We're going to look for edge dissection. I look distally, I look proximally. There's no edge dissection. I can have a sign of relief. And then I'm going to look for expansion, and the software will show us that we're greater than 90% expansion to our distal reference and greater than 90% to our proximal. The software on this particular study was the older software. The new one automatically does it for you. It breaks the vessel in half, and you see in the box that your expansion is greater than 90, or whatever your expansion is, distally and proximally. It does it automatically. Here I did it manually, 90% proximally, 99% distally. And at position, you have a white bar, which tells you you're opposed. If it's not opposed, it'll be yellow or red, and you'll see that shortly. That tells me I have stent expansion. So this is precision angioplasty with IVL. I had a heavily calcified lesion that statistically would not do well with balloon angioplasty. I used 1-to-1 balloon to size of the vessel. I managed my pulses where the calcium was using co-registration with OCT. And then I finally OCT to get a great result. And here you see the baseline and final areas, which are excellent. And the takeaway points. And when I talk about OCT, I actually think it stands for optimal calcium treatment, because we use imaging is useful at every step. It assesses the morphology, defines nodular, superficial, or deep. It tells me the length of the calcium, the arc of the calcium, and the depth of calcium. I can assess length of stent, go to normal tissue, the size to get the best IVL shock. Co-registration tells me where to put my pulses as well as my stent. And finally, I know that I don't have dissection, I have luminal gain, and I evaluate apposition. I want to thank you for your time. And now I'd like to give you the pleasure of introducing Rob Riley, who's really a giant in this area. Rob, take it away. You're going to talk to us about pooled analysis.
Well, thanks so much, Rich. Those were some fantastic slides and really amazing insights into how IVL works from an OCT perspective. Really seeing it on the screen, I think, illustrates some of the potential and mechanisms so well. So now we want to transition to the why and look at some of the clinical evidence that's come out, particularly a pooled analysis of the Disrupt CAD 1, 2, 3, and 4 studies. These are my disclosures. So this pooled analysis design was looking at Disrupt CAD 1 through 4, as you can see on the right side of the screen, 72 global sites in 12 countries, and then looking at 30-day follow-up. There was uniform study criteria endpoints, adjudication, core lab, follow-up. Safety endpoints was the same for all 30-day MACE, and then same effectiveness endpoints as well, looking at procedural success. We also did some multivariate analyses looking at predictors of MACE and procedural success, along with some subgroup specified analyses on safety and effectiveness. These are the study characteristics of each of the Disrupt CAD 3 studies. You can see here the dates, countries, the centers, and the number of patients enrolled. Again, uniform definitions here. Target lesions were severely calcified lesions. You can see we looked to be under 40 for all of them, under 32 for 1 and 2, and then 30-day follow-up was obviously very good for all of them. These are the pooled characteristics, which again is not really that surprising, right? A lot of the comorbidities that go with having severe coronary calcified stenoses. If you look here at the core lab analysis of the lesions treated, you can see most of them were non-left main lesions per protocol design. You can see on average reference diameter that we treated was a 3, significant stenosis there. Length of about 25, calcified length being beyond that, being treated, and then obviously the majority having severe calcifications. And then here at the bottom, you can see that 30% were bifurcations. Now, true bifurcations, so 111s were excluded from these studies, but this just means 30% had a branch involved in the lesions that were treated. You can see here some of the procedural characteristics. Looking at procedural time, about 64 minutes is pretty reasonable, especially when we think about treating severely calcified lesions. 1.3 IVL catheters used on average. Most of the pulses being used, as you can see there, just 1.3 stents on the average, and then the majority were post-dilated. Again, not surprising in severely calcified lesions. You can see the majority were radial, although still some people using femoral kind of holding on there. But again, the majority radial, which is great, right? Because we think about so many of the adjunctive technologies we have to use, needing larger guides. But here again, we're really able to stay 6 French here. You can see some of the outcomes here. You can see the diameter stenosis work its way down as we go post IVL, and then post stent implantation, which correlates very well with the minimal lumen diameter continuing to work its way up as we go post IVL, and then post stent here. If we look at If we look at complications immediately post-IVL, again, very low. Dissections being 1.8% being the major driver there, but again, that's reduced post-stent to 0.2, really down to one patient in the pool analysis there. Again, so extremely safe technology. If you look here at 30 days at the MACE, again, the majority of the MACE is driven by the non-Q-wave myocardial infarction. Again, that's going to be CKMBs above 3 times the upper limit of normal. Again, these were mandatory blood draws post-PCI. A lot of discussion about what that really means. There's been a lot of discussion about which definition should we use, what's the limit that actually has a clinical meaningful impact. Again, this was designed to be comparator to other calcium modification technologies. So just some interesting thoughts there. If you can see here, again, the MACE is going to be the same, no statistically significant difference in the pooled analysis across the 4 studies. Same thing with procedural success. And that's actually really interesting because you can see here, despite early use versus latter use, different patient populations, different comorbidities, again, the same procedural success and MACE rates. Look at secondary endpoints at 30 days here, again, similar results is obviously shown here. Target vessel MI at 6.9%, TLF at 7.2% being the major drivers. We look at multivariate analysis. Independent predictors are not surprising here. Bifurcation lesions and prior MIs being the major statistically significant drivers there for procedural success, although for MACE, again, very consistent with prior studies looking at other either calcium modification technologies or even stent technologies, bifurcations, prior MI, and lesion length being drivers there. Subgroup analysis, very similar here. Lesion length and bifurcations driving the MACE subgroup analysis, as can be seen there. And then procedural success, again, the same thing, lesion length and bifurcation lesions. So in conclusion, this pooled analysis represents the largest assessment of IVL in severely calcified coronary lesions. These pooled outcomes show very good safety and effectiveness profiles in a very severely calcified patient cohort, more significant than anything else we've seen published to this point. Consistent outcomes across studies, countries, patient profiles. So again, this gives us a very good signal for safety and procedural success here. Subgroup analysis showed consistent IVL treatment benefit across multiple high-risk patient and lesion cohorts. And then again, very consistent with prior studies, bifurcations, prior MI, and longer lesions being independent predictors of MACE and lower procedural success. So thank you guys so much for having me here. And I'll transition over to Dean.
Well, I'm Dean Kereiakes, and as I said before, I'm a consultant for Shockwave Medical. And it's clear that vascular calcification is becoming a bigger and bigger problem. With the increasing age of the population we treat, the prevalence of diabetes, chronic kidney disease, and hypertension, it impacts large bore catheter access, and it impacts the outcomes of DCI. Intravascular lithotripsy is a novel therapy for modifying vascular calcium, and we're learning a lot about IVL, from the modification of the sonic pressure waveforms used in extracorporeal shockwave lithotripsy to intravascular lithotripsy, as shown on the left, with a reduction in peak positive and negative pressure waves, to the consistency of data across clinical trials and continents, to the impact of calcium microfractures demonstrated in both preclinical and clinical data using intravascular imaging on vessel compliance. And there are more data coming. By the end of this year, we'll have Disrupt CAD3, 1-year follow-up, and the pooled patient-level analysis of 250 patients enrolled into the OCT substudies of Disrupt CAD 1 through 4. And finally, there are more data coming from coronary post-market studies in over 6,000 patients, including NCDR in the United States. This will provide information on important subgroups not included in clinical trials. In the future, we'll have more data-driven algorithms for treating coronary calcification, such as that proposed in the recent SKY consensus document. These will be important for providing us with data-driven care for our patients. And now I'd like to start the Q&A with a question directed at Bobby A. Bobby, we've seen kind of an abbreviated, expedited learning curve with IVL. Is there any specific lesions that physicians starting out with IVL should stay away from? What words of wisdom would you provide to those who are starting out to use this new technology?
It's a great question, Dean. You know, if you look at Disrupt CAD3, there was a run-in phase, as you know, And that was the first case of each operator. And if you looked at the results of those first cases versus all others, you saw that there really was very little learning curve to the use of IVL here. I mean, it's traditional balloon stent, balloon technology that I think most people are comfortable with. So there isn't a huge learning curve. Now, that being said, I think that what you don't want to go about doing is tackling the most tortuous, toughest lesion that you've seen the very first time you've used it, because it does take some learning to understand what the balloon can cross, what types of lesions it can cross, and what you might need a little bit more work up front to get the balloon across. It doesn't deliver like a semi-compliant balloon. It delivers, it's more of a bulky balloon. But with adequate preparation, sometimes you need to get a balloon in first to expand it. Sometimes you need a little NC balloon to get it in there. Sometimes you need some guide extension to get it in. So the tougher lesions. So you might start to really understand what the technology can do with a lesion where you're not expecting the more difficult challenges of balloon delivery. But then over time, I think you'll get comfortable with what you need to get the device across, whether it be more guide support, guide extension, buddy wires, et cetera.
Bobby, I have another question. And that is, we know that CAD3 was single-arm non-randomized. They used a performance goal, however, clearly derived from the Orbit 2 trial, using a similar population, similar endpoint, similar definition. At this point, would there be any reason in your mind to support a large-scale randomized head-on comparison between IVL and another, if you will, calcium-modifying technology?
It's a terrific question. It's something that I have thought deeply about. With you, Dean, you and I have worked together on a number of randomized clinical trials, and I think we are both trialists at heart. We believe in the power of randomized evidence. That being said, one has to think about what it is that this technology is trying to achieve. And IVL, like other atherectomy devices, is an enabling technology. It's a technology that's meant to facilitate the delivery of the definitive treatment, which is the placement of a stent. So in and of itself, it is not a technology that I think would be straightforward to evaluate in a randomized setting. And for what it is intended to do, which is better expand arteries, facilitate stent delivery, and do so safely, I think this is one of those situations where a single arm trial can demonstrate that. There are times where the stent won't go, then and an NC balloon won't expand. This could be an N of one trial to demonstrate that the stent won't go with standard technology. You get an IVL, the vessel to expand, and the stent is delivered. That is the outcome you're trying to achieve. I believe that translates to better hard outcomes over time. But I don't need a randomized trial to know that it facilitated the intention of delivering a stent. So that's sort of my thought process about it. Certainly would love to see randomized data to emerge, but I don't need that to understand, at least in my practice, where the value of the technology is.
Great. Thank you very much, Bobby. I have a question for Ziad. Can you summarize, in your opinion, what is the biggest difference between intravascular lithotripsy compared to all the other calcium modifying technologies?
As I summarized in my penultimate slide, the major differences between IVL are that it's really not dependent on wire bias at all, because it's a balloon and it'll expand circumferentially within the vessel wall. The energy delivered is circumferential. It is compatible with basically any wire, and that it provides more calcium fracture the more calcium there is. And with atherectomy techniques, really there is a great benefit with the crossing of the device, but then the mechanism of calcium fracture is really dependent upon the wire bias, which intravascular lithotripsy is not. Thank
you very much. For Philippe, can you tell me, are there any anatomic targets you think are not appropriate for IVL? Aorto-osteo, shelf-like calcium, is there anything that you wouldn't go after, if you will, with this technology?
Yes, in terms of anatomical location that might be perceived as a limitation for IVL, it's clearly the first one that came to mind is when it's very tortuous with very tight or hard to cross lesion. So I believe when it's very hard to cross, we may consider other modality to debulk, such as rotational atherectomy. especially when there's some sort of tortuosity where the deliverability might be problematic. Obviously, there's a way to overcome that with body wire, with the catheter extension. But in some cases where, especially where the lesions are distal or very narrow, very tight, and there's some tortuosity before, that might be a little bit more challenging. But I've been performing these cases and I succeeded to overcome these challenges most of the time. But when it's very, very narrow, I believe maybe we can debug with rotational atherectomy first and then follow by IVL if needs to be. So what we call rotatripsy or yeah.
Well, thank you, Philippe. I have another question, and that is, when do you pull IVL off the shelf if intracoronary imaging is either not used or not available? Do you use it if you have a non-dilatable lesion based on angiographic criteria alone? Give us some help with that.
So it's a very good question. So not always we will be using IVUS or CT. Some center have less experience with this, and this is okay. Personally, I like to use physiology, so I'm going to use IVL in two setups. First of all, I have a really low threshold to use IVL. When I see something, when I see calcium, even on one wall, I will use IVL. So because we always know that if you see calcium, even in one wall on the angiogram, you will see more in IVUS or by imaging by OCT. So as soon as I see calcium on the angiogram, and I use 1-for-1 non-compliant balloon as a pre-dilation, and I see some waste or some dog bone, even minimal, I will use the IVL catheter.
Excellent. I have a question for Rich Shlofmitz, and that is there such a thing as too much calcium? And I'll go twofold here, really. I sound like the three bears. If the ARC of calcium is less than 270, or even less than or equal to 180, is IVL maybe not necessary? That's too little calcium. And on the other end, is there the potential for too much calcium as you've seen it in use? Let us know.
Well, Dean, in the trial, we only looked at 270-degree calcium. And what I could tell you from 270 to basically circumferential calcium, there was not such a thing as too much calcium. We had great fracture. Sometimes I had to use more than one catheter if it was deep and it was long, but there wasn't a situation where we didn't get a great stent area. Even if OCT didn't show fracture because maybe it was microscopic, we got great results in these very calcified lesions. So I don't know if there's a situation where there's too much calcium. Potentially nodular calcium may be a problem in a smaller vessel. In a larger vessel, we see fracture in the calcium, but we don't ablate the calcium off. In a large vessel, that may not be clinically significant. In a smaller vessel, I might be more concerned that takes up some space. We are currently now, after the trial, since it's post-market, we're looking at 90-degree, 180-degree. To answer the question you had, is intravascular lithotripsy helpful in less than 270-degree calcium? If we have a situation where a balloon technology doesn't work, it's something that we could go to, and we have been going to, but that question hopefully will be answered within the year.
Thank you, Rich. Tell me how you manage your pulses, if you will. We know that the pulses emanate from the emitters. Only the, I think, M5 has one emitter where the shockwave magnitude is greater from the central emitter. But how do you adjust the C2 catheter to optimize the delivery of the sonic pressure waves?
Well, Dean, I use OCT when I do any type of angioplasty, but especially with calcium, I find it critical. And with IVL, it's an ideal marriage because you have 80 pulses and you want to maximize those pulses to get the calcium. And we know that greater than 180 degrees is where we really need that energy. So when I scan the vessel, I can mark with co-registration exactly where the calcified lesions are. Maybe in a 28 millimeter length lesion that I'm about to stent, maybe only 15 millimeters of that is calcified where I need to use it. So I focus those 80 pulses, maybe 40 and 40 in those two areas. But since the catheter has diffuse energy throughout the balloon, it's not concentrated in one spot, and the emitters are 4 millimeters in from the proximal segment and 2 millimeters in from the distal. I think I got that backwards, actually. It's 2 and 4 the other way. So I move the balloon approximately 2 millimeters when I'm focusing on an area, so I can get the 2 emitters centered right around that calcium. So you need a little catheter manipulation to get it just right, to maximize your energy. And I use co-registration with OCT to find the calcified areas where it's needed most.
That's fantastic. Now, for Rob Riley, are there any unanswered questions remaining from your clinical perspective? You've looked at the cumulative CAD 1 through 4 data in 628 patients. You have the clinical experience now. Is there anything else that remains unanswered from your perspective?
Yeah, I mean, I really think that is the question, Dean. You know, we now know that the device and the technology works. We know that it's safe. And now the question is, how does it fit in the profile with everything else? What are the imaging characteristics that are really going to drive use of this technology? We're starting to see some of those play out, being reproduced in different studies in terms of thickness, length, and arc. But then what are the other characteristics that might drive this technology versus some other technologies? And when we use other technologies, like let's say, for example, atherectomy, when do we need to also use IVL? And so these are some of the questions that we're going to have to continue to work on so that we can really get a comprehensive view of how to treat calcium.
Thank you, Rob. Tell me, from the pooled data, did you have any surprises, really? Or did it just reinforce your confidence and reinforce the observations of Disrupt CAD 3? Was anything else surprising to you in any way?
I think what was surprising to me, to be honest, was the consistency of the results across all 4 studies. You know, anytime we see a new technology being utilized, we expect there to be some heterogeneity in either procedural success or potentially MACE as we continue to figure out the best types of lesions to employ it, how best to employ it. But the fact that it was so consistent across all 4 studies was really surprising with this new technology. But it does fit with what we saw in Disrupt CAD 3. We saw that there was no significant difference between the roll-in patients and then the formal pivotal population that was studied. We saw there was no difference in procedural success or safety points there. And again, that really just reinforces the facts that the technology is easy to use, it's safe, and it gets the job done. And so to me, it both reinforced the points, you know, that we already brought up, but also was pretty surprising to see that so early on. So very exciting to kind of see how this moves on from here.
Well, that's been a tremendous program, very instructive. I'd like to thank each of our presenters, Bobby, Ziad, Robert, Rich, Philippe, and I want to thank Shockwave for sponsoring this session in a tremendous, I think, educational resource for everyone who will watch it. Well, thank you. And as they say, let's keep cracking.